sub-analysis of post-paradigm HF heart failure study, look at the risk of hyperkalemia. We always worried about the risk of hyperkalemia, but look at this graph. The orange color bar line is those patients who are on MRA, that is mineralocorticoid receptor antagonist with enalapril, and this blue color bar line is those patients who have mineralocorticoid receptor antagonist with sacubitril and valsartan, that is ARNI. And look at the incidence of hyperkalemia. It's significant decreased incidence of hyperkalemia, especially the severe hyperkalemia that led to your treatment stoppage is quite lower in those patients who are receiving sacubitril valsartan on top of MRAs. Similarly, when we compare this enalapril with ARNI, with the presence or in the absence of mineralocorticoid receptor antagonist, the risk of significant hyperkalemia is quite low in those patients who are receiving this ARNI as compared to those patients who are receiving enalapril alone. And when we talk about the renal effects and associated outcomes during angiotensin-neprilysin inhibition in heart failure, the inclusion criteria for this study, which was published in Journal of American College of Cardiology in 2018, they compared the enalapril, sacubitril, valsartan, and what they conclude that compared with enalapril, sacubitril, valsartan led to a slower rate of decrease in GFR and improved cardiovascular outcomes even in patients with chronic kidney disease. So this blue line is with sacubitril, valsartan, that is ARNI, as compared to this black line with enalapril, and look at the preservation of GFR in the two groups. And even we compare the urinary albumin creatinine ratio, this is quite significantly preserved or decreased risk of increased UACR in those patients who are receiving this ARNI as compared to those patients who are receiving enalapril alone. So when we compare head-to-head with ACE inhibitor versus ARNI, ARNI scores over better preservation of eGFR as well as decrease in urinary albumin creatinine ratio. Now this chart is very important. What to do when there is a worsening of renal failure? So as I mentioned, if serum creatinine increases by less than 50% to a maximum of 2.5 milligram per deciliter, and if your maximum serum potassium is 5 or less than 5, nothing need to be done. In fact, we can up titrate the dose of ARNI and evaluate renal function and electrolytes. But if increase in serum creatinine is rise by 50 to 100% to up to maximum of 3.5 milligram, and if serum potassium touches 5.5 millimole per liter, then we need to evaluate the clinical status and other causes of worsening renal failure. And now in this condition, we need to consider halving the dose of ARNI and again re-evaluate for this GFR as well as for potassium. But if after starting this ARNI, if there is a doubling of serum creatinine and it going beyond 3.5 milligram per deciliter, and if your maximum serum potassium is more than 5.5, then we need to evaluate clinical status for other cause of worsening renal failure, and temporarily we need to consider for stopping this ARNI and again re-evaluate. Now, when we can re-challenge our patients with ARNI, seeing the robust benefit of ARNI on heart failure, we can re-challenge this molecule after 2 to 4 weeks, possibly with a lower dose after correcting whatever the modifiable factor is there. So after correcting the modifiable factors, we can re-challenge our patients with lower doses of ARNI after 2 to 4 weeks of stopping the drug. Now we have lots of study regarding the use of ARNI in renal outcomes across the spectrum of ejection fraction in heart failure. So here is a Paradigm HF and Paragon HF study. And when we look at this secondary outcome, that is kidney outcomes, what are those that are sustained decrease in eGFR by more than 50% and stage of end-stage kidney disease or renal death? So look at the hazard ratio, 0.56. So there is a 54% relative risk reduction with the use of valsartan, with the use of this ARNI as compared to use of Valsartan or enalapril alone. And look at the separation of curve right from early days. The two curves separates regarding the proportion of patients who achieve this secondary kidney outcomes like eGFR more than 50% in distress kidney disease or renal death. And again, this ARNI slows decline in glomerular filtration rate when compared with enalapril or Valsartan. So look at the curve. This is the curve with ARNI as compared to the curve with Sacubitril or Valsartan alone. And when we compare the major adverse renal outcomes with ARNI versus enalapril or Valsartan, look at the hazard ratio of 0.56, meaning by there is 42% relative risk reduction with the use of ARNI as compared to Valsartan or enalapril. So end-stage renal disease occurred in 0.2% of patients with ARNI as compared to 0.4% with those patients who are receiving RAS inhibition alone. Now, when we compare the renal outcomes in Paraglide HF and Paragon HF trial, so look at the result. The ARNI reduces the risk of renal composite outcomes compared with Valsartan. The hazard ratio is 0.6. So 40% relative risk reduction with the use of Sacubitril Valsartan as compared to Valsartan alone. And the best part is the time to first nominal significance comes within the 2 months. So look at the early separation of curves as well as the nominal significance within the 2 months where their outcomes are going in favor of ARNI as compared to Valsartan. Now, when we look at the individual component, so all the components, right from whether it's a 50% decline in eGFR, whether it's a end-stage renal disease or whether it's a renal death, all favors ARNI, but this renal composite endpoint and 50% decline in eGFR is statistically significant, but stage of reaching end-stage renal disease and renal death are non-significant. But numerically, this all data favors this ARNI as compared to Valsartan. And this is ARNI slows decline in eGFR. We already know this is upper curve is for Paragon HF trial and versus Paraglide HF trial. In both the studies, they have the different population, but ARNI scores over Valsartan in both the studies. So conclusion for this first part, that approximately 1 in 4 patients with HFrEF in Paradigm HF trial were classified as having at least high KDIGO risk of chronic kidney disease. Such patients experienced the highest risk of cardiovascular event, mortality, and had the worst health-related quality of life. The cardiovascular and kidney protective benefits and overall safety profile of ARNI relative to enalapril remained consistent irrespective of KDIGO risk category, with no significant attenuation in efficacy at highest risk category. Taken together, the clinical benefits of Sacubitril Valsartan are consistent across the continuum of kidney risk and further support consideration of ARNI even at the patients at higher or very high risk of kidney disease. Now, coming to the second part, and we'll discuss in brief the other molecules. And here is a systemic review on this cardiovascular benefits and safety of ARNI in end-stage kidney disease. So it's just recently published in KI reports, and what they conclude that this systemic review suggests that this ARNI benefits even end-stage kidney disease with HFrEF and MRF by improving left ventricular ejection fraction without increasing the risk of hyperkalemia, hypertension, or angioedema compared to standard care. And this study I was talking, it's still this KI report has recently published that they are quite helpful even in those patients who have end-stage renal disease. So especially in those patients who are on dialysis and having no urine output, the risk of hyperkalemia is lowest in those patients. So I can easily use this molecule in those patients.